They were jumping right into one of the most intense, high-stakes procedures in all of medicine, the trauma laparotomy. Think of it as a race against the clock, where every single move a surgeon makes is measured in seconds, and the prize is a human life.
So let's just get straight to the heart of it. Picture this. A patient is on the operating table, bleeding to death internally. Their life is literally hanging by a thread. The challenge isn't just fixing the injury, it's finding it in the first place, amidst all the chaos inside the abdomen. So how do surgeons possibly win this race?
Well, the first step is as direct and decisive as it gets. It's a single, powerful incision to open the abdomen. You just can't hesitate, because every sign points to one terrifying fact. The problem is inside, and the only way to solve it is to get in there and get in there fast.
But before anyone even picks up a scalpel, surgeons have to make that huge life or death call to operate in the first place. And the evidence for that decision? It comes from understanding the nature of the trauma itself.
And what triggers that call really depends on how the person was injured. So you've got blunt trauma, think car crash. A surgeon is looking for things like unstable vital signs plus a positive FAST exam, which is an ultrasound to find internal bleeding. But then you've got penetrating trauma from a gunshot or stab wound, and the signs there, they can be brutally obvious. We're talking about things like peritonitis, which is a severe inflammation inside, or even evisceration, where internal organs are actually exposed. Okay, so the decision is made. Go. And the operating room just explodes into this whirlwind of frantic but super disciplined preparation. And believe me, these few minutes are every bit as critical as the surgery itself. And underpinning everything they're about to do is this core philosophy: damage control. Look, the goal here isn't to make everything perfect. Not yet. The goal is to stop the major bleeding, control any contamination from bowel injuries, and get the patient off the table. This buys the team precious time to stabilize them, to fix the deadly triad of clotting failure, low body temp, and high acid levels in the blood before they come back for the final repairs. And when we talk about readiness, the scale is just immense. The team hits the button on a massive transfusion protocol, making sure blood's ready to go. They're grabbing specialized vascular tools because they have to be ready for anything. And look at the skin prep. It runs from the chin all the way down to the knees. Why? Because the surgeon has literally no idea what they're walking into. They might need to open the chest or even grab a vein from the leg for a critical repair.
All right, this is it, the moment of truth. The incision is made, the surgeon is now inside the abdomen, and for the first 60 seconds, there's only one job: control the chaos of a massive hemorrhage. The strategy here is just a masterclass in knowing what matters most. First, a long incision from the breastbone down to the pubic bone to get maximum exposure. Then, without even trying to find the source of the bleeding, they just start packing all 4 quadrants of the abdomen with surgical sponges. This simple act of applying pressure buys them the most valuable thing in the world: time. Time for the anesthesia team to catch up with blood transfusions and get the patient stable.
I know, it sounds almost crude, right? But it is so incredibly effective. It's like building a temporary dam to stop a fatal flood. It allows the team to stabilize the patient and turn what was an unwinnable fight into one they can actually manage. Okay, so the massive bleeding is under control, for now. That's when the next phase kicks in. The chaos has been tamed, and now it's time for a methodical, systematic hunt for every single injury. And to do this, surgeons rely on a kind of mental map. They divide the retroperitoneum, that's the deep space behind the main abdominal cavity, into 3 distinct zones. And this isn't just for getting their bearings. Each zone has its own very specific rules of engagement that tell a surgeon exactly what to do next. So let's break down those rules. Zone I, right in the center with the huge aorta and vena cava. If you see bleeding there, you have to explore it. No question. A major vessel injury is almost a sure thing. But in Zone 2, over by the kidneys, a surgeon only explores if that bleed is actively getting bigger. And in Zone 3, down in the pelvis, a stable bleed from a pelvic fracture is often best left alone for other specialists to deal with later. This isn't guesswork. It's a battle-tested algorithm for survival. So you might be wondering, how in the world do you even get to these deep, hidden zones? You can't just push things aside. Well, surgeons have these brilliant maneuvers. They're like the surgical equivalent of finding a secret passage, letting them get behind entire organ systems for a crystal-clear view. First up, you've got the Maddox maneuver. This is a left-sided rotation. The surgeon cuts along the left side of the colon and swings that entire block of organs, the spleen, pancreas, colon, sometimes the kidney, over to the middle. It's literally like swinging a massive door open to get a perfect, unobstructed view of the aorta. And now for the other side, the right side. There's the Cattell-Brosh maneuver. Think of it as the mirror image. The surgeon mobilizes the right colon and the small bowel, swinging them up into the left. And this exposes the other great vessel, the inferior vena cava, plus the right kidney and duodenum. Between these two moves, a surgeon can get to almost any critical structure they need to. So once they've explored those deep spaces, the focus shifts back to all the other organs. And this is not random. It's done in a very specific order to make sure absolutely nothing gets missed. They check the stomach, front and back. They meticulously run the bowel, checking every single inch of the small intestine, then the large bowel, then the solid organs, and finally, the diaphragm and bladder. It's a full top-to-bottom search. Okay, so all the injuries have been found. The surgeon now has the full picture. And this brings them to the final critical decision point of the whole operation. And it circles right back to that philosophy of damage control we talked about at the start. And the question is this simple but huge. Has the patient stabilized enough to handle definitive repairs right now? Or is the smart play, the safer play, to pack the injuries, get out, and come back in a day or two once the patient is stronger and more stable? And when we say leaving the abdomen open, this is what we're talking about in modern surgery. It's not just left exposed. A protective layer goes over the organs, then a special foam and a vacuum dressing. This thing is amazing. It protects the organs, pulls out excess fluid, and helps keep the abdominal wall from shrinking back, which makes the next surgery a lot easier. You know, this whole process just highlights the incredible level of judgment that's needed. An experienced trauma surgeon knows all the classic pitfalls. Not prepping a wide enough area, bad communication with anesthesia, making an incision that's too small to see what you're doing, or even the opposite mistake, using damage control on a stable patient who doesn't need it, which just creates a whole new set of problems. And when you take a step back and look at all of this, it leaves you with a really profound question. I mean, it's one thing to understand the steps. It's another thing entirely to actually do them under that kind of pressure. What does it really take, in skill, in courage, in discipline, to make those kinds of life or death calls in seconds, with a person's life literally in your hands?